All right, I just want to welcome everybody to tonight's OE World Tour event. And tonight we're going to stop on a journal club, which is a little bit different compared to how the rest of the OE World Tour has been going. For those of you who haven't or who have been tuning into the other sessions, tonight's going to be a little more interactive. So I encourage you all to join the discussion. Feel free to turn on your video cameras, unmute yourselves, and join in with any questions you may have as we're going through various studies tonight around upper extremity fractures and trauma. And also, this is not the end of the OE World Tour. There's still 2 more events coming up, one later tonight and a finale tomorrow. So just go to oeworldtour.com to find out a little bit more about the rest of what's going on and what's left to check out. So without further ado, welcome everybody to Upper Extremity Trauma Club tonight. Both myself and Dr. Moin Khan from McMaster Orthopedics will be taking you through a variety of articles and the latest and greatest of evidence around upper extremity fractures and trauma. Dr. Khan is an orthopedic surgeon and sports medicine specialist at St. Joseph's Hospital, where he specializes in the cutting edge of upper extremity surgery. And myself, I'm an orthopedic trauma surgeon at the Hamilton General Hospital Level 1 Trauma Center and deal with a variety of upper and lower extremity injuries. But tonight we're going to be focusing on the top half, and we're going to be taking you through a variety of studies that have been prepared for us in conjunction with OE, where we selected the latest and the best quality evidence to start off a discussion around all kinds of injuries. And also we have selected these studies based on reports that have been viewed in their popularity online, as well as just trying to pick studies that highlight the real current challenges we face in upper extremity trauma moving forward. So again, I encourage you to unmute yourselves, raise your hands, join the chat with any comments you may have as we're going through this. We'll discuss a few different studies at a time, but we'll focus first on radius fractures here, and then we'll have another session on upper extremity humerus fractures, and a period to chat around each group of studies. But if you have questions with each study as we go by, feel free to chat or raise your hand, and we'll try to encourage involvement as we go. So I'll kick things off with radius fractures here. In the first study, looks at operative versus non-operative treatment of Mason type 2 radial head fractures. So fractures of the radial head that are minimally displaced, but still displaced beyond 2 millimeters and may cause a block to rotation. The study comes to us from the Netherlands, and it's a randomized controlled trial where they took patients with Mason type 2 radial head fractures and randomized them to 2 arms, either operative treatment or non-operative treatment, to compare the 2 groups with respect to function at 12 months. A follow-up. And they took their they took their patients and randomized 23 patients to open reduction from fixation, 22 to non-operative. And the 2 groups were comparable as we intend to have with a randomized controlled trial arm to arm. And they found that there was no real significant differences between the 2 groups with respect to function at 12 months as measured by the DASH scores. And similarly, no difference with respect to Oxford elbow scores and the Mayo elbow performance scales. So, important functional tools couldn't really distinguish the difference between 2 groups, and no significant difference as well in clinical assessments with range of motion, pain score, and pain score completed at the 1-year mark. And here's a graphical depiction of all that. And as you kind of go top to bottom, we have the operative open reduction from fixation on your left and non-op on the right. And as kind of indicated by the gray color between the 2 groups, there's no real significant difference or superior treatment with respect to the different outcomes that the groups looked at. And again, they're small groups, so it's hard to detect differences even if there was one, which also leaves some questions for some questions we could pose in the discussion. But I'm going to turn it over to Dr. Khan here to discuss a couple other studies before we jump into some chats.
Awesome. Thanks so much, Herman. Again, just a reminder to everybody, if you have some experiences you want to share as well, or your clinical expertise, definitely interested in hearing that as well, how you're managing these. So this is a randomized control trial that's comparing operative versus non-operative treatment in acceptably reduced interarticular distal radius fractures, published in 2021 in JBJS. Next. And the question that the group asked was, in patients with acceptably reduced interarticular distal radius fractures, how does volar plate fixation compare to the non-operative treatment? And they looked at functional outcomes up to 12 months follow-up. Next. And so this is how things were broken down. So 90 patients in total were randomized, 46 to cast immobilization and 48 to volar plate fixation, and similar baseline characteristics and age groups as we would expect, again, with a randomized control trial. And the important findings, really, that patients in the operative group had improved PRWE and DASH scores at all time points, and patients in the operative group also had improved scores in the physical components of the SF-36 compared to those patients treated non-operatively at the 12-month mark. The operative group also had improved, The operative group also had improved early range of motion and grip strength at 6 weeks, and similar range of motion and grip strength at final follow-up. And there were no real differences in pain scores at any time points, and overall complications were similar. So this is it, sort of broken down graphically, patients with cast immobilization versus volar plate fixation. And you can see here the lower scores are generally better scores with respect to patient-rated wrist evaluation scores and wrist functional scores and DASH scores. You can see they really favor the volar plate fixation. Again, SF-36 scores higher in the volar plate fixation, and those are some complications. All right. The next study is volar locking plates versus external fixation in operative distal radius fracture. So this is another paper published in JBJS in 2021. Next. And this group really looked at displaced extraarticular distal radius fractures. How does volar locking plate fixation compare to external fixation with respect to patient-rated wrist and hand evaluation scores at 1 year post-op? And so this was a larger study, 156 patients. These were adult patients between 18 to 70 with displaced, unstable extraarticular distal radius fractures that were deemed operative by the treating surgeon. So these were randomized to 2 groups. 75 patients received a volar locking plate and 81 patients received external fixation. And so what were the important findings? Well, patients who underwent volar locking plate fixation actually had significantly improved scores at the 6-week mark compared to external fixation group. And these differences really didn't persist past 3 months and the 1 year follow-up. And volar locking plate group also had improved quick DASH functional outcome scores at 6 weeks and 3 months. And at 1 year follow-up, the volar locking plate group had significantly higher range of motion with regards to wrist extension, ulnar deviation, and radial deviation. Radiographically, results were similar with the exception of ulnar variance, which was significantly less in the volar locking plate group. Next. This is a graphical representation of outcomes. And so on the left, or in the purple, volar locking plate versus external fixation. Patient-rated wrist and hand evaluation scores lower, so meaning better in the volar locking plate group. Similarly, patient-rated wrist and hand evaluation at 1 year, again, lower, meaning better in the volar locking plate group. With regards to function, again, these DASH scores, quick DASH scores at 6 weeks and 1 year, lower, meaning better in the volar locking plate group as well. Looking at range of motion, higher being better in the volar locking plate group at 1 year, and with regards to wrist extension, ulnar deviation, and radial deviation. And really the incidence of adverse events were similar between groups.